Thank you for watching this webinar. My name is Asbel Montes, and I'm the Vice President of Governmental Affairs and Reimbursement for Acadian Ambulance Service. I also chair the Ambulance Payment Reform Steering Committee on behalf of the American Ambulance Association. This webinar today will kind of go over some key points of what we're trying to do as we reform the system. We're going to first cover the current healthcare environment. Second, we will kind of go through a risk analysis of the ambulance industry, and then we'll get into the meat of the presentation regarding the ambulance payment reform initiatives. So let's get right to it. There are two proposed payment models that Health and Human Services has been exploring over the past 2 years. One is the alternative payment model, and one is the value-based purchasing model. The alternative payment model is more commonly, for those that know, there's Accountability Care Organization, is more of a bundled payment model. Currently, 20% of the payment, of the way that payments are made are in this type of model. They're forecasting what HHS's goal was, that 50% would be moved into that, and that it would actually reduce Medicare spending. Value-based purchasing is where you've seen that out regardless of any conference that you've been to, talking about how fee-for-service was actually going to be moving into that 90% of fee-for-service by 2018 would move into value-based purchasing, that it would improve patient outcomes, it would cut payments to low performers, so you would see the incentive-based if you achieve certain goals through the value-based model, or if you didn't, you would be disincentivized as well, and there would be kind of a penalty for that. I do want to make sure that everyone absolutely knows when we talk about 90% of fee-for-service, it's important to understand where ambulance fits into the spectrum of things. Most people probably do not realize, but out of the whole healthcare spend, ambulance makes up little less than 1% of the spend. So we're about a $5.8 billion industry a year. In the overall spend of healthcare, it's about 1%. Of course, most probably know hospitals and physicians make up the majority of the spend when it comes to healthcare. So not to mitigate or to diminish that we will move into a value-based purchasing, but I do think we have some time to work through our ambulance payment reform initiatives, and that we're not as susceptible as some may believe into moving into this fee-for-service by 2018. So keep it into perspective. If the feds are looking to mitigate costs to the program, they're going to focus on that 80-20 principle. So where am I going to focus the majority of my time to get 80% of the result? That's kind of what common practices that we use in business as well. So they're going to use that 80-20 principle as well here. And so hospitals and physicians are really going to get the magnifying glass on value-based purchasing and even these ACO or alternative payment models. But I think value-based purchasing is really something that is gaining traction and that is showing, based upon some of the demonstration programs that are being doing, that to be fruitful and to be a cost containment measurement. So just a little bit about alternative payment models. The Health Economist, the Kaiser Family Foundation, kind of looks at that and says, are these savings really long-term? Are they just one-time success stories? You know, the Kaiser Family Foundation came out as well, is will the ACOs actually really lead? I mean, there's some requirements. You've got to have at least 5,000 lives. So can smaller providers engage in these models? What this is saying is that there is some concern from some leading organizations. Is the alternative payment model really going to work long-term, or is it just a short-term solution to help mitigate cost? There's also been several concerns about the value-based purchasing piece. And this is some area where they've really got to look at some different things with that, as it deals with some of the current quality measurements that they're looking at. So if you're looking at any of the value-based purchasing models that they've come up with, it does rely on a lot of clinical measures. It's administratively burdensome. There's been a lot of concern from the provider community about the administrative burden on that. It also creates an incentive for providers to only look at those exact care processes that are being measured. So, and we all face this in some of our businesses as well, is when you actually just focus on a certain measurement, that's what gets the focus and everything else gets forgotten about as well. So there needs to be a marriage of the two as we work through that process. We got to look at the resources available to providers as you get through the value-based purchasing piece of it. And I think that you're going to see a lot more in this administration focused on while the objectives are good, maybe the implementation hasn't been done so well that we need to kind of work through that process to figure out what areas do we need to refine to get some of those measurements that we need through this value-based purchasing process. There's also some concerns from MedPAC. Now, MedPAC is the bipartisan commission that was established to look at certain goals and initiatives that are being done in the Medicare payment space. In short, but basically what they've indicated here that's on your screen here is that Medicare's quality measurement system seems to be increasingly compatible with the Commission's goal of promoting clinically appropriate, coordinated, patient-centered care at a cost that is affordable to the program and beneficiaries. So what MedPAC's concern is that some of these value-based measurements that they're putting together actually is going to cost the system more money to achieve a very marginal decrease in savings or patient quality of care as well. So there needs to be a marriage of that it might be incompatible at this point in time. So there are some concerns as we continue to venture into this new territory and new space that maybe it hasn't been as well thought out as it should be. Now, as we know, Secretary Price has been confirmed and has been on the job for a few weeks now, and he is a doctor. And he's been on the record many times, and especially as of the taping of this webinar, we're in the middle of the American Health Care Act and the passage of that. They want to give more choices to consumers. They also want to give more decision-making to the physicians. And they also want to give a lot more decision-making to the states. So I think what we're going to see under Secretary Price is absolutely there's going to be some repealing and replacing of the Affordable Care Act. What it's going to look like, we're monitoring that as of the taping of this webinar. I mean, it could be that essential benefits go away and are more directed to what the states allow, which kind of goes with the mantra of what Secretary Price has indicated across the board. As you can see in this chart, what he supports. What's unclear about is his vouchers. He is against state expansion of Medicaid. He is also against women's access to reproductive health care as well. But the key thing is, and especially in our industry with the mobile integrated health piece, and we'll kind of talk about that later, is he does support the Centers for Medicare and Medicaid Innovation. So I think that you are going to see more regarding the Medicare and Medicaid innovation. I do think there has been concerns about how that has been implemented, but in theory, the objective of the Innovation Center, it appears they're going to continue to keep that in place under this new administration. Now, as of the taping of this, CMS Administrator Seema Verma has been confirmed at this point. She has an extensive background in working with Indiana, and so if you've heard of the Healthy Indiana Plan, as it deals with Medicaid, her expertise is very centered into Medicaid. So I think we're going to see a lot of change around the Medicaid space. Our industry typically on the federal side is focused a lot on the federal initiatives, which is Medicare, and our extender packages, and we'll kind of get into some of that component because that is very key. But if you have not been paying attention on the Medicaid space, whether it was with the Medicaid expansion, there could be some changes to the way states do things with Medicaid. I do think you're going to see a lot more autonomy given to the states without some of the regulatory burdens from the feds on how states can actually move into some innovative care as well. But the Healthy Indiana Plan that the new CMS Administrator Seema Verma is probably a very good roadmap for you to look at on how you think that they will structure some of this Medicaid. Let's kind of get into a little bit of the background regarding our industry, what we've been through, kind of a risk assessment of what our industry, especially notably the ground ambulance industry, over the past several years. There are a few reports that have come out regarding our industry. One more notably is the 2007 Government Accountability Report. There was also one done in 2012. There was a MedPAC study done in 2013, and of course MedPAC is that bipartisan commission that looks at payment rates. And then you have the Office of Inspector General that gave a 2015 report regarding waste, fraud, and abuse on our industry. And then the Centers for Medicare and Medicaid Innovation and some of the grants that were awarded, or innovative grants that were awarded to our industry. So let's kind of go through a few things regarding the GAO reports that came out that actually raised some questions among policymakers on the Hill regarding the differences between the findings of the 2007 report and then the 2012 report that came out based upon a requirement in a legislative vehicle. The 2007 report basically concluded, and most of us know this if you've been advocating on the Hill or you've been staying up on our extender packages over the past several years, is that on average it showed that ambulances had a margin about 6% below the cost of providing the services or the reimbursement of Medicare. In the super rural areas, it was 17% below the reimbursement cost. And the AAA had actually done a survey as well that actually concluded those findings. I think the AAA came out with about 5.5% was what we were getting reimbursed that was below our cost, or getting 5% reimbursement below the cost of providing the service. So it kind of aligned with what the GAO report provided. Now, in 2012 is where things changed a little bit. And our industry, really, when we saw this report, it was very, very concerning. And a lot of us went to the Hill, and we had to really educate our legislators because it really was not an apples-to-apples comparison when you read the GAO report of 2007 to 2012. But what it did is it still concluded that Medicare still reimbursed service providers less than the cost of providing the service. However, the median of the Medicare margin with our add-on payment, they indicated was either 2% to 9% over the cost. So they basically had indicated that it was 2% below what we were getting reimbursed, or you were making 9% margins. And then the median Medicare margin, if you excluded the add-on payment, was a minus 8% to a 5%. It also concluded that in that period from the original GAO study to the GAO 12 study that it did see a 59% increase in BLS non-emergency transports. So there were some discrepancies in that when it has such a wide varying margin there. And what we concluded too is that there were several of the ambulance services that they had actually interviewed and had been a part of the GAO study in 2007 that were no longer in existence or didn't respond back to their GAO 2012 study. And so then they were factoring in other organizations that may have been new or had been around much longer. And so it really didn't do an apples-to-apples comparison through that process. Now, with the expansion of the non-emergency piece was very, very interesting with the increase of the 59% BLS non-emergency transports. At that same time in 2013, MedPAC, the Medicare Payment Advisory Commission, came out with a report. They were asked to commission a report by Congress to study the industry regarding the add-ons and whether they should still continue on with the add-ons and any recommendations that they would make for different policy. What MedPAC came out with was that they basically recommended to Congress that they should allow the temporary ambulance add-ons to expire. They also directed the Secretary to rebalance what they call the RVUs, or the relative values, for our ambulance industry by basically saying reduce what you pay to the non-emergency services and increase what you pay to all of the other ground emergency services, ALS, as well as the ALS non-emergency. They also directed to replace the permanent rural shortage mileage add-on that we currently have today and kind of adjust it to more in those geographically isolated low volume areas. It also had a second recommendation that it directed the Secretary to promulgate national guidelines for medical necessity. It also basically said put in some national edits for claim processors to not pay for claims that they shouldn't be paying for, which, interesting enough, is something that the fiscal intermediaries that already pay for Medicare claims should be doing already. So it's kind of interesting that there would be a recommendation to do something that they already should be obligated to do. And then also to look at different geographic areas and actually put in maybe a moratorium or a temporary moratorium on those areas as well. Dialysis transports was a very prime concern, which actually backed up that 2017 GAO report where it did see a 59% increase in BLS non-emergency transports. It also did see a rapid increase in non-emergency dialysis-related transports, and it was very interesting in the states where there was a huge number or increase in those dialysis transports. And this chart here just represents the MedPAC representation from October of 2013, which kind of identified those states that really had a spending per beneficiary for dialysis that was really higher than most. Puerto Rico was just off the charts. So they're not really included in here, and that's why you see Puerto Rico really outside the norm. I mean, they were really an outlier in their spending per beneficiary. And so then we get into the OIG report that came out. And this was a report that came out that actually identified a few different things where the Office of Inspector General looked at Medicare Part B services that were paid for ground ambulance. They were looking to identify certain vulnerabilities, inefficiencies, or fraud trends, and then making some recommendations to minimize inappropriate payments to the ambulance service. So this 2014 work plan came out, and it basically raised a few different concerns. One was the increase in utilization. I think it's extremely important to note that based upon this report that came out in September of 2015, is that they were looking at 2012 claims, and they found that 2.7% of all of the claims that they examined were questionable. And I think that needs to sit in, is they brought this to the forefront saying out of all of the claims, only 2.7% of the claims that we examined were questionable. Did not mean that they were paid inappropriately. It just meant something didn't seem right there. Either they looked at certain things and they didn't find that there was a physician claim for a transport that happened, or a dialysis claim for a because they were looking at different payment files. What they did notice is that 52% were in the Philadelphia, LA, New York, and Houston areas, which, interesting enough, is a correlation where there's been temporary moratoriums put in place for abuse in the dialysis area. They also found that 21% of all suppliers had one or more claims with a questionable billing practice. What they recommended at that point was to put in a temporary moratorium, which is nothing new. The Secretary has been exercising those temporary moratoriums in certain geographic areas across the United States for several years now. They also recommended that ambulance suppliers include the NPI number, or the National Provider Identifier, of the certifying physician on all claims. They also indicated that they should implement a new claims processing edit to improve existing edits to prevent inappropriate payment. They also indicated and suggested that it should increase its monitoring of ambulance billing, as well as identify in the report that CMS should take appropriate action against those providers that were identified in the OIG report as having questionable billing practices. The results were not bad. So out of the whole broad scheme, there was less than 3% of the claims that they found that were questionable. And of those 3%, just because they were questionable did not make them wrong. It was just they didn't understand some of the nuances of ambulance billing, specifically like Medicare doesn't cover doctor's appointments, but Medicaid may. So you may have dual eligible patients there as well that may be covered on certain things. But it wasn't bad. However, of course, the media gets involved. And basically it indicated Medicare paid more than $50 million in fraudulent ambulance rides. And as we know, that is not what the OIG report indicated. It was questionable. Not that they were fraudulent, but that there was questionable. The data was questionable at that point. And then most of us saw when you dial the 911 and Wall Street answers, I mean, our industry went into an uproar. I think we made a little much ado about nothing on that. It did appear to die down. What we thought might happen on the Hill could be a negative effect to some of our ambulance payment reform. Really was much ado about nothing, and our industry since moved on. Now, the ATRA report that came out, which was the American Taxpayer Relief Act of 2012, when it was passed, basically requested that the ambulance industry explore cost reporting as a way of reporting information back to CMS. So there it did ask that a vendor look at this and provide a report back to Congress, and that was in the ATRA, or in the American Tax Relief Act of 2012. What this report concluded is three things that I've highlighted in red here. One was that it would be difficult to develop a standard cost reporting for all the ambulance providers and suppliers because of the unique nature of our industry and the unique organizational aspect of our industry. It also looked and said, any cost reporting tool must take into account the wide variety of characteristics of our industry, and also that it must standardize cost measures to ensure that the smaller rural and super rural providers and suppliers are represented. When you look at the data, it does indicate that 73% of all ambulance suppliers and providers that bill the Medicare program bill less than 1,000 transports a year. Now, when you look at the data, and we're looking at data that's publicly available to us from 2014 and 2015, the new data just came out as well, there are about approximately 10,000 ambulance suppliers and providers that bill the Medicare program. So I want that to sink into the ambulance community because a lot do not realize that 73% of all ambulance suppliers and providers bill the Medicare program less than 1,000. Another interesting statistic to note is that of the 73% that bill the program, they only make up 3% of all of the transports that are billed. So 73% of the 10,000 ambulance suppliers only make up 3% of the transports that are billed to the Medicare program. So it's very, very important when we look at the cost, and we'll go into this in detail, that we encapsulate all ambulance services in this process. So what is it going to look like? What will payment reform look like under our new GOP administration? Regardless of where you stand on the aisle or not, I mean, history does prove that under more of a more conservative Republican administration, typically healthcare does not bode so well because, especially for the ambulance side of things, because we are a safety net. We predominantly do a lot of emergency transports as well. We are that safety net provider for individuals that may not have coverage. They may not have a primary care physician. So when they do get sick, they call 911. Is they do call us for transport. And so typically under that, we are Medicare and Medicaid are our largest payers. And in a more conservative philosophy, those are entitlement programs, and we want to give choice to patients or what have you. Cuts begin to happen more in the entitlement program area. So what will this actually look like? And we'll kind of go through that. Nobody really knows at this point if you're following it. It's changing daily at this point. Currently, as of watching this webcast, and by the time that you actually see this, the decisions will already be made on the American Health Care Act regarding that, but that could have some dramatic impact on what happens with Medicaid expansion in those 31 states that currently have it, what that's going to look like, what the grandfathering in of those individuals will happen, when it will actually expire. That is very notable as we continue to move through this process. And what will the federal ambulance payment reform look like at this point? I'm very optimistic about that piece, especially looking at that the leadership is still looking at innovative ways. How do we cost contain? How do we bend that cost curve? This is kind of the pathway for the repeal of the ACA. We're already going through that process. It does appear that the reconciliation process is just one area of that piece. Anything with a funding mechanism to move it through with a simple majority. There's a lot of executive actions the Secretary can take to repeal some of the provisions that they may not like in the Affordable Care Act. That does give the Secretary discretion to do certain things. There's going to be some administrative actions that you'll see happen as well. That could happen through the process. And then also addressing some of the midnight regulations, whether it's through the Administrative Procedures Act, an executive memorandum, a Congressional Review Act. I think you're going to see lots of different avenues that this executive branch and congressional delegation will take over the next year or two to repeal some of the provisions that they may not like and the constituencies that voted for them may not like. So what does this mean for us in ambulance payment reform at this point? Number one is a cost survey or cost data collection piece. Really trying to get away from the cost survey language at this point because it entails that we're going to be looking at a more of a survey approach. So we're kind of trying to refer to it more as a cost data collection system. You may see it as cost survey, cost data collection system, trying to really change the narrative on that. Supplier to provider. is probably, in my opinion, one of the most key components that we need to get past this year. That's very impactful to our industry. We'll kind of go into the reasons why. The third thing we need to then is tie payment to cost, then quality. That is very important. We do not need to get that out of context. We need to first tie our payment to our cost, then to quality. And then the fourth thing that we need to do through ambulance payment reform is the money should follow the appropriate mode of treatment. So let's kind of talk through the evolution of ambulance payments. And we're going to go back to 1997 when the Balanced Budget Act actually created the fee-for-service for all types of our services. So if you were around then, in 1997, that's when the Balanced Budget Act passed, that they were creating a fee-for-service environment for all types of our services. In 2000 is when negotiated rulemaking established our current payment categories. And if you were around during negotiated rulemaking, you were probably pulling your hair out at that time. It was very labor-intensive. It got everybody there to the table. And the current payment methodology that we have now was a direct result of that negotiated rulemaking. In 2003, the Medicare Modernization Act created the actual add-ons and these infamous add-ons that we have been lobbying on the Hill that have been temporary for, the last, 14 years now. In 2013, our industry experienced a rate cut, a direct rate cut to non-emergency BLS repetitive patients that originated from residences. It was a 10% cut across the board for those transports, and we feel it was a direct impact of that MedPAC report, some of the 2012 GAO studies that had come out regarding the increase in the BLS non-emergency, especially in the dialysis space. In 2014 is when we really begin to advocate for our intermediate reform. This is where the cost survey, cost data collection piece really came in, the extension of those add-ons to be made a little more permanent. We did get almost a little over 2.5 year extension for those add-ons that do expire at the end of 2017. And then, of course, we don't really know what it's going to look like, but we're trying to drive the train on what we would like our ambulance payment reform and what we would like it to look like in the future, but really relevant to cost data and looking at it from more of a data collection system. When we actually go through the process of looking at how we actually get paid as an industry. So just a quick slide to kind of show you where we are on ambulance extenders. Of course, right now we have a permanent rural shortage mileage that is permanent. The two components that are still temporary are rural and urban, as well as our super rural at this point. So these are the 5 pillars for the key of the American Ambulance Association reform principles. One is the stability of to create stability in the ambulance marketplace by making these temporary add-ons permanent. Every year, we've at least had it for a few years now on this relief for the add-ons and giving us at least a longer window than just a year on these temporary add-ons, but we really need stability in the marketplace as we continue to put our budgets together going forward or what have you, that there's always this question mark, is this temporary relief going to be made permanent or is it going to expire? Cost survey, cost data collection, and I need to update my slide presentation here as well as we move into that new vernacular on the cost data collection system, is we really need long-term reimbursement based upon our costs. So we know if you're doing your own data internally within your own organization based upon the 2007 GAO studies, the 2012 GAO studies, we are being reimbursed below our cost. We know that. The problem is we need data as an industry. We also need the reform to be scalable. There are so many different sizes of services, different operational issues. As I indicated earlier, 73% of all ambulance suppliers bill the Medicare program less than 1,000 transports a year. That's a huge number. And so any reform that we do must be scalable to include the industry as a whole. Prior authorization is another piece that we're really looking at. It does address fraud, waste, and abuse. and it will provide, especially for repetitive patients, non-emergency repetitive patients, there has been some demonstration programs that have actually shown that it is a cost containment measure. There has been also some issues that it has shown that it's created some access issues. So there's going to have to be a balance between that prior authorization and how it's implemented. And then, of course, quality is something that not just the ambulance industry, but the healthcare industry in general, as it moves it more patient-centric, and under our new secretary, as well as the new CMS administrator, they've been on the record several times talking about making everything about the patient and much more patient-centered. So what's our strategic approach as we kind of work through this piece of it? The one thing is we really want to be treated as healthcare providers. Right now, we are kind of almost like a widget. We're not, we're technically a supplier. We're more than just a taxi. We expand the emergency services beyond the ERs. We define non-emergency services, that it is actually still a provision of healthcare in the non-emergency world. We need to probably define that a bit clearer and more. We need to leverage our healthcare expertise as ambulance services to improve patient outcomes. We need to track our costs. We need to protect the add-ons, which means we need to make them permanent. And then we need to link our payment to the cost of providing those services. So a few years ago, we created an industry partnership with this Payment Reform Steering Committee. For many years, many individuals looked to the American Ambulance Association as being all things reimbursement. But as we begin to navigate the payment reform landscape, there were many other stakeholders within the ambulance industry that may not have just been a part of the American Ambulance Association that were very interested as we begin to move into this mobile integrated health space, community paramedicine, or what have you, that we needed to engage. So we reached out to some of the national associations that have a very large footprint as well as a political footprint as well. We reached out to the National Association of EMS Physicians. We reached out to the National Association of EMTs and the National Association of State EMS Officials, and we created what we called the Ambulance Payment Reform Steering Committee. And this committee, after its inception, came together with a joint paper that will be available on the National Association of EMTs website, as well as also available on the American Ambulance Association's website. And it's a document that kind of walks through the key pillars of what I'm going to be discussing today, and what we've all agreed upon and industry aligned on is the future of what we need to be doing with ambulance payment reform. So there's a short-term, intermediate, and long-term payment reform timeline that we have put together. One is the cost survey, the cost data collection piece. The one is the supplier to provider and the permanency of the ambulance extenders. That is a very short-term goal that we want to have done by the end of this year. The first 100 days is key. We would love to get that in the first 100 days, but that's all going to be dependent upon what begins to happen in the healthcare landscape. But there are several packages that we can actually get our bill in that you'll be advocating for at EMS on the Hill into a probably more broader comprehensive package. But the cost data collection piece, the supplier to provider provision, and the permanency of the extenders will be in that short-term effort. The intermediate area is, and we'll get into a little dialogue about that, is the alternative destination transport piece, where we can transport outside of just going to the ED, but why can't we go and transport to an urgent care center? Why can't we transport directly to a behavioral health unit? That actually is a regulatory function. It could actually be done by CMS in a regulatory way. It does not really need to be done through statute, through a legislative vehicle, but could be done through a regulatory change. Treat and refer is something that will have to be done via statute. There is no current payment mechanism for that as well, so there's a funding piece that would have to be talked through that process. Also looking at the expansion of emergency services, maybe we need to clearly define some things with emergency services as well as non-emergency. That could be, we've all talked about all the bariatric transports. We're all having to pay more. It's costing more money to do bariatric, where we have sometimes extra attendants that have to respond. More ambulance units have to respond. We have to get more expensive stretchers. We have to have bigger units. But there has really been no compensation component for certain different provisions or higher cost drugs that we may be mandated to have. Then more long-term is really moving into the mobile integrated piece of things, where community paramedicine falls into, the alignment of our clinical and reimbursement. How do we align that piece from quality metrics and things like that? That's more long-term as we begin to demonstrate these type of different innovative practices and the savings across the country. So let's kind of go through some of the short term and what we're actually looking at in this very, very, very short term. Of course, we want to increase the Medicare baseline. I've kind of walked through a few of those pieces. This just kind of outlines it in this slide, what we're looking to do at this point. The supplier to provider provision is why. Why do we want to become providers? Number one is suppliers do not provide healthcare services. By the mere definition of how CMS looks at it. It's more like providing a commodity, equipment, supplies, transportation, taxis, wheelchairs, DME, that's probably the best way to note things as well. Also, your costs are set based upon the commodity. For instance, like DMEPOS, durable medical equipment companies, they're subject to competitive bidding. So in states where there's a lot of competition, CMS could put out a competitive bid saying we're only going to use 3 ambulance suppliers in this area to provide non-emergency ambulance services. Is emergency services subjective to competitive bidding? Probably not. There's so many regulatory and local and governmental regulations and local ordinances and statutes that govern how 911 operates, that for it to really be subjected to competitive bidding from a Medicare payment standpoint is probably not going to happen. You do lump yourself as a supplier into more of that competitive bidding aspect, into being more of a commodity. And as we've known, over time, we're a relatively new industry compared to hospitals and physicians as well, but we've evolved over time from just being load and go patients, load them up in there before the funeral services used to take them to the ED, the live ones and the dead ones that would transfer to the funeral home. They wanted to get out of that business, and when we actually started, that was pretty much what it was way back in the 60s and 70s. But over time, we have, with medical direction, with protocol direction and driven, we are really some of the only access point to healthcare in some communities within the United States as well. So we've evolved over time as an industry. We provide life-saving medical care, and many institutions recognize that. This slide just kind of gives you an example of the healthcare services that we absolutely provide as ambulance service providers and suppliers. We've evolved as an industry. We are providers of healthcare. And we said technically we refer to as providers of healthcare, whether we technically continue to stay as supplier, for instance, like physicians are considered suppliers by the technical sense of the word, but always referred to as a provider and treated as providers and part of the pre-healthcare continuum as well. Our non-emergency, they are medical services. We focus on patients' needs. They're morbidly obese, mental behavioral health issues. We administer oxygen for those that can't self-administer as well. There's certain special handling and positioning that only medical personnel can provide to certain patients. We provide advanced airway management, suctioning, isolation precautions, IVs in non-emergency situations. So there are certain things that we are doing in a non-emergency transportation world or ambulance transportation world that's still the provision of healthcare services. And so it's very, very, very important that we recognize ourselves as providers, whether it is in the technical sense of the word or we are referred to under the Social Security Act, and depending upon where we're going to amend ourselves, and we're working through language like that as an industry and pretty much have that, and we're working with our sponsors on that piece at the taping of this webinar. Regarding why we need to be recognized at that point, because it is inappropriate to consider a healthcare provider that is providing healthcare services. We're not providing a widget, we're not providing a commodity, but we are actually providing a healthcare service that it's inappropriate to even lump us in to allow that for competitive bidding. Also, our payment rates need to recognize the cost of providing that healthcare service. And it's also important for us to raise that bar to reduce fraud, waste, and abuse as well in our industry. So what does it mean to actually be a provider? So what does that mean to the ambulance community if we are going to be referred to as a provider? There's 5 key components that it would mean for our industry. One is it would require a survey or you to participate in some type of an accreditation process. The states usually can put that on together. It could be that you could use any accrediting body at that point in time. That would be done in conjunction with the stakeholder community when they promulgate those rules as well, but it would require a survey or participate in some type of accreditation process. It would also mean that you'd have to sign a participation agreement with CMS, which you already currently do. Nothing of that would change, whether you're an ambulance supplier or provider at that point in time. Consider it as well, you already do this. It would require that you submit claims electronically unless you're a small provider. You already do this. It's not a change for the ambulance industry. It would also require that you provide cost data to CMS. This is going to happen whether we are referred to as supplier or providers. It's going to happen one way or the other. We're going to provide cost data to CMS. And then it's also going to require that we submit some type of quality data to CMS as well. It also, to help combat the fraud or whatever, it would require some conditions of participation. So basically what it would do is it would set a federal standard for how providers operate and interact with beneficiaries. So there's some provisions that would look in here that would talk about the organizational administration of the ambulance services, the administrative and medical records, how you keep that, compliance with other laws, personnel safety, patient rights, certain things like that. And a lot of these things, there's already other certain laws you're required to do certain things with, to come up with certain procedures as well. But remember, state and local requirements would always remain primary. So this would not negate anything that you're already required to do on a local or state requirement. So there's already some of these things already listed here that many of your states already require as well. So it would not circumvent any of that. And provider status is necessary. It is necessary to align our rates with our cost. Our current rates are set using data from negotiated rulemaking that did not take into account some of the costs of these services. And it's also important for the non-emergency ambulance service community as well, that it really is a healthcare service that we're providing in the non-emergency ambulance space as well. It's also needed to allow for the reform, and this is where it gets into some of these innovative projects that many of the ambulance services are doing. This is a part, you're needing it for the clinical triage piece of it, for the alternative destination transport piece of it, because of the decision making that is being involved, in the healthcare decision making that's being involved to reroute individuals that they call into your 911 system, to triage them through the process to say there's an alternate mode, an alternate healthcare delivery site that actually could take care of you. And then the mobile integrated health component of this, the community paramedicine piece, that would fit into that mobile integrated health design from the ambulance industry, as well as the mobile integrated healthcare practitioner, as well, that would fit into these models that we would need it in order to be to move through some of these payment designs that we need. And the thing to note before I move on as well is this just opens the door. It does not mean that you have to do it. There are many that I hear from the ambulance community that say they have no desire. It doesn't really work in their area to do any of these mobile integrated health or community paramedicine functions. This does not mandate that you do that. It just opens the door to allow you to begin to do that and to get reimbursement for what you do, especially on the federal and federal payer level. So with that, I'm going to now move into the cost data collection system piece and why it is important and what that would mean for our industry as we begin to work through that, and what does a cost data collection system mean. There are many that may be watching this as well that may do certain cost reporting on the state level for certified public expenditures that you may get once a year. It would look something very similar to that. Not necessarily the exact same thing, but it's going to look very similar. Some of the same information that you're probably gathering for that cost report that you may be doing for that certified public expenditure, certain things like that. It will look like something, if you want a comparative of what that's going to look like. So just to recap on that, the strategic approach for that cost data collection piece is this is the risks that we face with the GAO reports that came out, the OIG, the ATRA study, the MedPAC basically concluded that there's not enough data in the industry to really conclude on things. We can basically indicate that they are getting reimbursed below the reimbursement that's being paid. However, it's always referred to in the studies that there's not a lot of data available from the industry. And Congress has begun to show much more of an unwillingness. As you can see, every time they pass something, they've recommended a study to be done. That's what ATRA was about. Or they've asked MedPAC to do a study on the applicability if the extender should be still done or not. And so there's an unwillingness to continue to extend the add-ons without some type of justification. Hence the reason why there has been a lot of information coming out regarding the cost data collection piece. I think it's very interesting for individuals to note that we actually have seen a downward pressure on our payment rates. Since 2009, the American Ambulance Association had one of the consultants do a study on this. It's a little under a 10% cut since 2009 that we have had to the industry. I think it's about 9.8% of a cut that we've received to the industry. One is through the productivity adjustment. And that compounded effect is a little over 5% of a cut that our industry has received since 2009. Everybody remembers when we used to be able to round mileage. The fractional mileage piece was around 0.8, 0.9%. Sequestration, we all know what that was. Payment cuts to address the fraud concerns, that was that 10% cut to the dialysis resident transports. And then most individuals didn't realize this because this was impactful in some areas and not in others across the United States, but the zip code redesignation based upon the census data that came out. That was also a cut because they misapplied some of that, some of the zip codes. There were some zip codes that went urban that really truly technically are rural, and that zip code redesignation also was a hit to the ambulance industry. So based upon the ATRA study, where the mandated study on the collecting of the cost data that Congress mandated, that they analyzed the industry on the ability for us to do cost collection, similar to how hospitals do cost collection. So it did ask for two different things. It basically asked to study and analyze data on existing cost reports that ambulance furnishes if you're a hospital-based provider, and to look at that and the characteristics of those providers. And then it also said, do a feasibility study on obtaining cost data on a periodic basis. I think that's very interesting to note, from the ambulance providers of services and suppliers to examine the appropriateness of the Medicare add-on payments. It also had a requirement in there to consult with the industry on the design. So the AAA had been working with the Moran Company and had commissioned the Moran Company to do a survey of ambulance providers to figure out if it was feasible to do something like a hospital cost report, or if we would need to do something else as well. Long story short, this was a study that happened and took an extensive amount of time, and the AAA paid an extensive amount of money for that, but it did conclude that we could not, as an industry, do cost reporting like hospitals do it. It basically suggested that we need to do something like a hybrid model. We would need to identify a standardization and a time of how often we could do it as well. And then it actually went through some describing the surveys and indicate where it was a unique nature of service that required a unique solution as well, and then indicate what also worked well. So that's what the Moran report did. Basically said, do a hybrid model. ATRA also supported that same exact thing. So another study that was done, that was commissioned by Congress, basically concluded with what the commissioned study that was done by Moran on behalf of the American Ambulance Association concluded as well, that an annual cost report was not a viable option for the industry based upon the unique setup of our industry. Also, that it could not obtain accurate cost data from the hospital cost reports that the hospital-based providers are already required to submit. It also indicated that any data tool must take into account the variety of the difference of ambulance services, so the governmental agencies, the volunteers, the privates, the for-profits, the public utility models, the hospital-based services. And that it would also be inappropriate to ignore the cost of smaller rural and super rural services. So also basically indicating we should not carve those individuals out, because their cost, and based upon the way that there's so many ambulance suppliers that comprise in the very small rural and super rural areas, when we go back to that data, 73% of ambulance suppliers out there, out of the 10,000 ambulance suppliers, bill the Medicare program less than $1,000, so it's very, very important that we continue to keep them in there. And it recommended and supported that cost collection and reporting methods needed to be standardized. So basically, the context here was driven by the congressional skepticism about data collection. So Congress basically had indicated, should we continue to keep doing the add-ons? We need justification for that. And so the project that we worked on for the last few years was to look at it, make recommendations based upon that, how cost reporting could actually happen at this point in time. So what is the data collection system that we are looking at from the American Ambulance Association versus what others do? So other Medicare providers, hospitals, physicians, other dialysis centers, nursing homes, they provide annual cost reports. They collect their total revenues, they collect their total costs. There is a general level of standardization, and this is used to evaluate their rates by MedPAC, the Congress, and CMS. Our approach, again, based upon the Moran study that was actually substantiated by the Congress mandated evaluation as well, what we call the Acumen study, was that we should do a sort of a statistical sample based upon the organizational design of our EMS. So if you were a fire, if you were a for-profit company, if you were a volunteer only, or a majority volunteer, it would take a statistical sample of the organizational design of that. It would make it mandatory that everybody reported, not every year, but everybody reported. It would also collect total revenue. It would collect total cost. It would have a very high level of standardization that would be developed, and there was a list of standardization that also we came up with as an industry, and it would be used to evaluate the rates by Congress and CMS. The way that we designed it was that the initial data collection would be that everybody would report the first year, and they would report based upon some of the key demographic data in order to define the cost data by categories. So to put you in a service delivery model, very similar to what I mentioned earlier. If you were a governmental entity, if you were a for-profit company, if you were a nonprofit entity. So there were certain categories, and so everybody would be mandated to fill out this kind of survey that would collect that information in the first year to be able to put you into certain categories. Then the cost data collection piece would begin to happen, and it was still mandatory. It would be representative of that survey method, so what defined category that you were put into as an ambulance service supplier, and all would report within that same category. And you would do it at least once every 3 years. And then, of course, we would collect revenue and cost data. And the purpose of that was to make sure that we got an accurate view of the cost by organization, by rural providers, super rural providers, urban providers, and to make sure that the information that we were collecting was useful to future payment reform. And so some of the data that we would be looking for, and this is not an all-inclusive list, but this is some of the data that would be looking for from the geographic data, would be the organizational designation, kind of what I've talked through, the percentage of volunteer EMT labor that you have, the volume of ambulance services that are delivered per year, the percentage of the Medicare emergency and non-emergency services you provide year, the average duration of your transport, if you have a sole source contract, percentage of transports that are urban and rural. We would also look at cost data. We would look at Medicare revenues, subscription revenues, most other of your private, if you had any public funding, uncompensated care, write-offs, labor costs, administrative costs, vehicle costs. Key component here that most people want to talk about is what I put in red, the cost of readiness. That will also be included in your cost data. And this is kind of how the cost survey process would actually work. The initial demographic data would be reported. CMS would then determine the categories. CMS would inform the survey group then that you would need it, and then they would evaluate your data. And that's kind of what the process would actually look like. Remember, this is probably the key component about cost data, and why you're hearing so much of this right now, why we're going around to as many conferences as possible to get stakeholder engagement in this. Hence the reason why we're having this webinar today, to educate you as you go on the Hill, is the industry must lead this. We must control our own destiny, because if we do nothing, then Congress will do something, and typically what the federal government does, we typically do not like as an industry. So it's very, very important for us to try to channel this ourselves and to lead this design. because there are others who would try to put us into that hospital model. And there are two studies, the Acumen study that was commissioned by Congress, as well as the American Ambulance Association commissioned study by the Moran Group, that has concluded a hospital cost reporting model does not work for this industry. It would be extremely burdensome, and it would result in, I hate to say it, junk data. And then we also need to protect our reimbursement rates. We do know, and basically has been indicated by several leaders in Congress, that in order to get the permanency of our extenders, we are going to have to cost report. Legislating this cost data collection approach, this is what H.R. 745 did on the House side in the last congressional session. We are working currently right now. By the time this webinar is done, we should have a bill dropped by then. Definitely by the time the first advocacy begins to happen with EMS on the Hill. There will be a standalone bill for ambulance payment reform, very similar to how it's always been in every Congress. On the Senate side, there'll be a companion bill on the Senate side as well as the House side that will illustrate these provisions that we need. It more than likely will not be a standalone bill that passes through the legislative process. It will be a part of a broader package. We're looking to have the extenders of these add-ons for at least 5 years. We want to make them permanent, which technically, in the broad scheme of things, is really a 10-year thing. Whenever CBO scores something on an extension, it's a 10-year deal. And then it also calls for the cost data collection model, which is the initial provider characteristics reporting and then doing the cost data collection system once every 3 years, as we've indicated there. And that's currently still in the process of being negotiated through, but we're almost in the final stages of that piece. So how to move forward on this? The Payment Reform Steering Committee leadership is what is really leading this initiative with all of the input from the other organizations that I mentioned earlier. The data collection, it must be a statistically valid sample method. I mean, we have to have it with all those characteristics. If we only get one group or characteristics providing their data, it does not help the entire industry. And because of the dynamic differences in our different organizational structures, it is important that everybody be included in this as well. And then the American Ambulance Association will continue to lead this effort in conjunction with the National Association of EMTs, the National Association of EMS Physicians, NASIMSO, and many other stakeholders that may not be collectively within because this is an industry initiative. Standardization is one thing. I won't go into this much, but there has been some metrics put together on a standardized metric for grant ambulance service recommendations. This will be in consultation with the industry and with CMS moving through to make sure that there's a standardization and a definition for what most people consider. This is what cost of readiness is. This is what Medicare revenues are, Medicaid revenues are. Something may seem very obvious, but there are some definitions that some individuals within their own internal organizations, they define them differently. So there does require a standardized reporting. The American Ambulance Association has developed this already regarding those recommendations, and we must implement them in order to succeed. So we're all going to have to standardize the way that we do things. This will be a partnership with vendors who provide revenue cycle platforms as well. Will be once we get this cost data collection piece together. So what are our next steps? Today, this is what the snapshot of the ambulance Medicare payment system actually looks like. Relatively very simple. We basically have a base rate. That's your ALS emergency, non-emergency, BLS emergency, and so on. And we have a mileage payment. And that is how we get reimbursed. As long as we transport a patient from either the residence to the ED and to a statutorily covered service by Medicare, you're going to get paid a base rate and mileage based upon the guidelines that are set forth from reimbursement. Here are what other systems look like and other Medicare payment systems look like. A little different than what we currently get as an ambulance industry. They have a base rate. They have adjusters. This is very important. It could be a geographic adjuster, could be a service complexity adjuster, could be a patient characteristic adjuster, could be a low volume adjuster. They also have where they address high cost of services. So a high cost drug, sometimes there's a pass-through payment. Sometimes it's an outlier policy depending upon the high cost of that component as well. They also have a market basket update that they receive, and there's also a quality thing. This is the bonus. This is a bonus payment they may get, or they may get a reduction in services based upon their quality score as well. So as you can see, other healthcare systems and Medicare payment systems allow for some of the things we are advocating for as an industry. That we really haven't taken into context with, certain high-cost drugs where like, how can we get paid for that? Especially the bariatric transports. That's probably the biggest thing that I hear as I traverse across the country is the morbidly obese piece. And most people's eyes begin to light up about that. But this is kind of where other systems allow for certain mechanisms like that our current payment system does not allow for. So our initial design on payment reform as it deals right now, just so people can kind of see it in a chart of what it actually looks like, is currently somebody has to call the 911 system, and we're talking about the emergency system, or they're calling your system for a non-emergency transport. They call in, we basically send a BLS unit or an ALS unit. If we treat the patient and we transport them to the nearest appropriate facility, to the nearest appropriate ED is typically where we go. That's usually governed by our local ordinances or our protocols. And we currently bill, like I just said, the base rate, whatever the applicable base rate, and how many miles it takes us to get that patient to that facility that's loaded in the back of the ambulance. The second thing that we can do that could be in the payment reform is that alternative destination transport. Actually, you could still continue to use your current billing method. Instead of taking them to the ED, I might take them to a freestanding ED. I might take them to an urgent care center. I might take them to a detox center or an outpatient behavioral unit. Any method that you work in conjunction with your protocols and your medical direction or what have you. That could be done regulatory. There's already a billing method system to it. There is some downstream savings that can be worked through. There's a lot of demonstration programs that have been done on this already. More notably, the Reno system has really got some academic-based data, some data that really shows that this innovative or this alternative destination piece really does work. The next thing is the treat at the scene without transport, or what we call treat and refer. This is going to require a new payment rate to be established. So this will have to be done statutorily, will be a part of the payment reform piece as well as we continue to begin to explore that and how that would actually work, maybe through more demonstration programs to be done across the United States. That could actually be done regulatory within the CMMI, is to petition CMS and work with CMS, which we will be doing, to maybe do more demonstration programs across the United States because we can't develop national payment policy on 1 or 2 or 3 different demonstrations because we know healthcare is very local. And so we're going to need several different demonstration programs in order to make national payment policy. Clinical triage is something as well that is being explored and is innovative and has actually shown as a call comes in, they can be triaged through the process and determine if ambulance to provide others. That this is new payment rates that have to be established. There's a lot of stuff that has to go into this. This is another area where we're probably going to have to demonstrate a lot more across the United States in several different regions if we're going to develop national payment policy, how that actually works, if that's more of a state-run thing, if that's something that the feds need to dictate to the states to do more, give money to that component. That is an area that is still needs to be navigated through the process from a national payment reform, that we don't put reform together based upon 1 or 2 demonstration programs that are showing the results, but healthcare is very local. So payment reform future, intermediate, long-term, not really assigning time frames to the intermediate or the long-term because things could happen very quickly. Intermediate could be 6 months. Intermediate could be 18 months. Long-term could be a year. Long-term could be 3 years. It depends upon the environment that is happening on the federal side, through the innovation side, how much gets pushed down to the states, different things like that. But we do know payment reform in the future and what is accessible to us as soon as we do cost data collection, we can start tying our services to actual cost. As well as moving into that supplier to provider, which is very important to any of these intermediate and long-term initiatives. Being referred to as providers is key. Alternative destination transports, treat and refer, again, expansion of emergency services, non-emergency is more of the intermediate. Some of that can be done regulatory, some of that can be done has to be done statutory. Long-term is the mobile integrated health services, the community care medicine processes, programs that interconnect with mobile integrated health on a national scale, and then of course alignment of clinical and reimbursement. As we wrap up this presentation today, there are a few things that I want to review because we covered a lot of information in this webinar. Short term, next 100 days is kind of our focus and our goal. However, it could be 9 months, but definitely by the end of the year, the provisions that we want to make sure happen this year. One is the cost data collection system that we reviewed extensively about. The second is the supplier to provider provisions. That is probably one of the key components that we really want to make sure happens, as many of you are interested in this mobile integrated healthcare concepts. There's no funding mechanism on the federal level for a lot of the constituencies that we cover as well. And then the third thing is to make sure we stabilize the market by making the extenders permanent. Now that is connected directly to the cost data collection system. So on behalf of the permanency of the extenders, we will also do cost data collection. The other important thing is to continue to keep alignment as an industry. So as we advocate on the Hill, it's important for these provisions, which will be very impactful to our industry, that we continue to stay aligned. There's a lot more information also available at the National Association of EMTs, as well as at the American Ambulance Association's website under the Ambulance Payment Reform section. You'll find a lot of information and a host of materials available that will really kind of walk through each of these components that I spoke about today on the webinar. As also there's some white papers available to you to use. There's also some legislative directions, some one-pagers that are available to you as well. And at the EMS on the Hill Day this year, you'll also receive a host of materials to distribute to your legislators as you meet with them. Thank you for watching.